Okay, good morning. This is Dr. Garais, MED110, and it is July 1st, I believe, and week 6 of term 3. And of course, by closing of business today, task 5, discussion 5, lesson 5 due today, and all late protocols are in effect. So what are we doing today? And again, thank you for those of you who showed up to lab. Those of you who haven't confirmed the lab date, please do so, because again, I need to know who's coming onto campus. You can't just pick a date and just walk onto campus. Potentially, if there's too many people on campus, you will be sent home if you don't have a reservation. Right now, this week 6 and going into 7 is not so bad, but by the end of week 7 to week 8, nursing will be in the house, and there's 120 of them who are taking labs. So, and the school can't have 20, 30, 40 people on campus. And it's nice and intimate. Last night's laboratory, yesterday morning's laboratory, only 4 or 5 people, the way we like it. Okay, so please reserve your dates. I need an official email. And if you didn't get a confirmation with instructions on what to do, then of course email me back. Now, what are we doing this week? Is what the first laboratory that we had last night, and the cardiovascular system. Now, if you look at this, the cardiovascular system, what are we doing is, here's our goals, because we're going to have to submit a task this week. Of course, we have to know who are the players in the circulatory system, the heart, of course, the blood vessels as well. So we're going to be talking about the heart in detail, and the 3 different types of blood vessels or tubes in your body. Of course, the main function of the heart is to pump blood throughout your body. And if you were in lab last night, we talked about how the vessels, the arteries and veins, and the arteries colored red in the textbook, and we saw last night when we opened up the heart, nothing was red or blue. It was 18 shades of brown and gray. So red in a textbook means arterial, which means that the majority of the red blood cells will be carrying oxygen, which is the fuel to along with glucose to make ATP that keeps your body running, including your heart itself. And then the blue is venous blood, which the majority of the red blood cell in venous blood carries carbon dioxide, and that is the waste product of metabolism of oxygen. Good morning, welcome. I'm just gonna mute you guys just to be sure. But if you can unmute yourself if you have a question. And again, feel free to stop the lecture and interrupt me during this lecture. So, of course, the players is the heart and the tubing, which is the cardiovascular system, which makes up the cardiovascular system. Now, there's, again, as always, the lab book here in step 3 of your task 6. It has some nice notes in it. They talk about blood. I'm not going to talk about hematocrit too much. I'll talk about blood momentarily, but I'm not going to talk about the labs too much, because you're going to have that when you take your clinicals and when you take any class that you have phlebotomy in. And again, of course, you're going to see it again in your pathology. You see the different blood tests like CBC, hematocrit, and all that stuff. You see that in multiple other classes. And this class is more about the parts and how the parts work together, and that's delving into laboratory. So that's the function. The heart needs to keep on pumping, and it has to pump rhythmically so that the blood gets to where it needs to go and delivers the oxygen and carries out the carbon dioxide. And that exchange of oxygen and carbon dioxide is called respiration. So respiration is not only just breathing. there's also an exchange between your tissues of oxygen and carbon dioxide all along your body. That is also called respiration. And then there's respiration of the exchange of oxygen into your mitochondria, and that's cellular respiration. So respiration now has an expanded meaning for you. It means the exchange of oxygen and carbon dioxide. That could mean the exchange between your lungs and the outside world. It could mean the exchange between your organ systems and your blood vessels. And it also could mean the cellular exchange between the oxygen that gets carried into the cell that goes into the mitochondria. And of course, cardiovascular physiology, how exactly, and we're going to talk about the electrical system of the heart, and you need that for your EKG classes. How exactly does this thing pump? And the heart is essentially just a muscle. So all muscles have to connect into some sort of nerve, and specifically for the heart, it's the cranial nerve 10. We're going to talk about that a little bit more detail. Then, of course, it connects into your brain. So your heart, you could see now, even though we're going to be talking about the heart is definitely connected to your lungs. And if those of you who took CPR, your heart and lungs are cousins. If one stops, the other one will definitely stop. So if you stop breathing, your heart's going to stop. It goes a few moments later. And if your heart stops for whatever reason, so will your lungs. So remember, we do teach this system by system, but it is definitely all related to each other. And that's cardiovascular, and that's what we're doing this week. So the first thing I want to show you is a video of let me go back. Last night in lab, I talked about it a little bit, but here I'm going to introduce it fully. Maybe I should just actually draw it. Let's see the quality of the video. If the video is garbage, because this video was done a while ago. Let's see. Here, the box diagram video. Let's see if it's. Okay, so let's watch this.
Oh, is this thing on? Apparently so. Let's check.
You can see it was done with an old camera.
Okay. Good evening. This is Dr. Garais, MED110 in P1, and want to review the box with you guys. And the box is really neat because it goes through several things. It can go through a little bit of external anatomy of the heart, definitely the internal anatomy, and also it goes also through the cardiac cycle. And again, for review, the cardiac cycle is the trace of a single drop of blood from the left atrium all the way through the cycle, through the systemic cycle, through the pulmonary cycle, and all the way back to the left atrium. So first, we have to always talk about conventions. Conventions are some of the rules of the land and how we're going to do stuff. Okay, I just want to make sure. Good. Okay, good. So, the first convention is we got to know our right from our left. Remember, we always look at the perspective of our patient. So if we're looking here, my patient's heart, this is their left side, this is their right. And the next convention is anything that's oxygenated will be colored in red. As you can see here, everything on this side of the diagram will be labeled in red, blood cell is carrying O2, oxygen. Okay? That's our fuel. And then everything on the right side, right over here, is colored in blue. And the majority of the gases on the blue side, the red blood cell will be carrying carbon dioxide. So we're breathing in. We want oxygen. And then when we use it all up, we want to get rid of the waste. And the waste product is carbon dioxide. And that's what we're getting rid of. Okay? So let's look at the box. When we look at the heart diagrammatically, it's essentially a box. It's a box with 4 chambers, also known as atria and ventricles. Separate out the box. Now you go home. If you can practice this by yourself and drawing this by yourself.
And I'll have a full picture of the box available in the notes today.
Much more complex. But when you really think about it, it's not that difficult if you do it a couple of times. So, all the little rooms on the top, they don't have any doors to it. They're just like hallways and they go right through. These are your low pressure chambers. This is your atria. Of course, this is your left atrium and this is your right atrium. And since that's on the left side, I'm going to label it in red. And that's the left atrium. And on the right, that's the right atrium. And then the 2 larger rooms or chambers, you have your ventricles. Left ventricle. And I wrote it in red because it is on the left side of this diagram, and the right ventricle. And I wrote it since it's on the right side of this diagram, right side of my patient's mind. So right now, you can answer some really neat questions regarding oxygenation or deoxygenation. I could ask you, right atrium, is it oxygenated or deoxygenated? And it is in blue. So therefore it is, and if you answered deoxygenated, you would be correct. It's blue and carbon dioxide. How about the left ventricle? Is it inferior or superior to the left atrium? It is inferior. So you can see, you could be asked and answer physiology questions and anatomy questions. Okay? So now that we've drawn out the box, and also do not forget that the box is separated into right and left by a septum. And the septum in between the 2 ventricles is the interventricular septum. Remember that prefix from your medical terminology. Inter means between. Okay, and you can see there's not supposed to be any communication between the right side and the left side. So the septum keeps everything separated.
All right, let me pause it. So I want to put a picture or a diagram of actual heart on the other side.
Everything on the right side
Pause this.
has to be deoxygenated. Everything on the left side contains.
So so many windows. So the box diagram makes this picture easier. Now, right off the bat, we already know that the heart diagram says that it's a box. So it's like this and like this. And the 2 atria, since we're looking at this has to be the left one, left atrium, and this one has to be the right. And this has to be the left ventricle, and this has to be the right ventricle. So everything on the left side, on the right side, which is this, you'll notice the tubes here also, they're all blue. That means the majority of the red blood cell is oxygenated. I'm sorry, backwards, scratch that. The blue, of course, the majority of the red blood cell is deoxygenated. And the right side is all pulmonary stuff, so that's your pulmonary circulation. And then the left side, your left atrium here, and your left ventricle here, they all connect into things that are red. You can see here, this is a tube for the aortic semilunar valve, and then it goes up here into a red tube. So everything associated with the left side of the heart is systemic and also oxygenated. So the box kind of makes it diagrammatic so that this is less complicated. And right off the bat, now you can identify this, and also you can even look online. You just type in internal anatomy quiz. It has the same exact picture like this, but all of this blank. And then you could fill it in, and then the website will tell you if it's good or not. So let's continue on with the box, and then it can also give you a hint on how to identify all of these valves, like these leaflets here. And just because you know your orientation, and of course this side, of course, is your patient's left, and this side is your patient's right, and the conventions of blue and red all stand. Blue, deoxygenated; red, oxygenated. And you can see the aorta, the largest artery. And if you recall lab, that's the hard patent tube that was coming up off the top of your heart. And this top of the heart is called the base, and the tip right here is called your apex. And here's the thing that in the video that I was just talking about, that's your interventricular septum. That's your internal septum. So a septum just means like a wall. So it's a wall, interventricular, in between the two ventricles. And another thing we also noted last night in laboratory, and again, you could see the atria are enlarged and exaggerated. Remember when we looked at the atria in the real heart? All the walls were smooth. But if you look at the wall of the ventricles, you could see how rough it all is, and had all had thick walls here, very thick here, a lot thicker than this picture. And then you had all these like forest, and that forest of trees is called trabeculae carnae, and that actually protects the walls of the heart due to the high pressures. Now, your atria, they're not going to have high pressure, so the walls are going to be thinner and they're going to be more delicate because there's no pressure. Blood just falls in there. And then, but for the ventricles, that has a lot of pressure because one side, the right side here, has to push blood back into the lungs via the pulmonary artery, and the left side has to push heart into the systemic circulation via the aorta, your largest artery here. Okay, so you got to use your imagination a little bit how this left ventricle, like the tube goes behind this and it connects here and then goes around. Okay, so I'm going to keep this, I'm going to try to keep this, or keep referring back to this picture. So where's the video? Let's go back to the video. Where's the video? Maybe I should move this. Down. Hey. That's not it. No, that's not it. Okay.
Red blood cells that contain the majority of the gases. These red blood cells are oxygenated. And the majority of the red blood cells on the right side of this diagram is deoxygenated, or it has carbon dioxide. So let's begin with one way. The blood can't go back up. And remember when we talked about arteries and veins? The veins have valves to make sure that the blood only goes one way. And the arteries have pressure to make sure the blood only goes one way. So from the left atrium to the left ventricle, we go through two doors. If there's two doors, then it's got to be a bicuspid valve. Since it's a bicuspid valve, there's also two names for it, also known as a mitral valve. Any of these valves that are here or here are AV valves, atrial ventricular valves. That means they are the valves or doors in between the atrium and the ventricle. Remember, it goes one way. After it goes through the left ventricle, it goes through a semilunar valve. I'm going to draw it like this. We saw a picture of why it looks like a semilunar valve, because it looks like kind of like a so if I have one semilunar valve on this one side, I gotta have one on this side. Remember, this is purely diagrammatic. I am not an artist here, but we have to look at things simply. Now, this oxygenated part from the left atrium to the left ventricle goes through the bicuspid and mitral valve, through the semilunar valve into the largest artery in your body, your aorta. Remember, arteries take blood away from the heart. So if it goes to the aorta, again, colored red, it has to be the aortic semilunar valve. And what side are we on? We're still on the left side. What side does the aorta have to come out of on the real heart? It's got to come out on the left side. Now, after it goes to the aorta, it goes to the rest of the body.
Either the body or what we say, the systemic circulation.
Circulation. Systemic circulation, rest of the body. Now, what happens when we go to the rest of the body?
Now, I'm going to skip that part because we mentioned that part where there's gas exchange. And when there's gas exchange, the oxygen that we delivered to the whole body gets exchanged for carbon dioxide. Because remember, every time I put fuel in a machine, what has to come out? Exhaust. And the human being's exhaust is carbon dioxide. So just to like kind of fast forward this video, you have semilunar valves on both the left and right sides. The left side is going to go to the aorta, so that's the aortic semilunar valve. And then the right side, it's going to go to the pulmonary artery, so it has to be the pulmonic or pulmonary semilunar valve. And remember, everything on the right side, that's the pulmonary circulation, and everything on the left side, that's the systemic circulation. So let's jump right to label that. This part. Now, after it goes throughout the whole entire body, it's got to come back to the heart. And vessels that come towards the heart are, of course, veins. Now, you have the superior vena cava that's going to come from your head, and it's going to empty out into your right atrium. And now you'll see the blood colored blue because the blood is now deoxygenated. We used up the oxygen, and now our systemic or the rest of our body gave us now carbon dioxide. And everything else from like your neck on down, which is your trunk, that all goes into the IVC or the inferior vena cava. Of course, inferior means lower, superior, upper, vena, veins, cava means it's big. It's not a small vein, it's a rather large vein. And again, this is a lower pressure. It goes into the right atrium. And if you recall, let's fast forward a little bit more. If I have 2 doors on the left side, I drew 1, 2, 3 doors on the right. So if this is the bicuspid, this has to be the tricuspid. And of course, we already talked about the pulmonary artery. It's an artery. It's going away from the heart, and we're going towards the lungs. So it is the pulmonary artery. And then just like how the blood went away from the heart and got deoxygenated, well, now when it goes through the lungs, it's going to get oxygenated, because what do your lungs do? You breathe in oxygen, and then you discard the CO2. So when the blood comes back to the heart, it comes back to the pulmonary vein. And the pulmonary vein coming towards the heart will get back to where we started from, the left atrium. And I'll have a photograph, a much, much better picture of this that has color. So you could see here, there's so many things from this diagram you could learn. Number one, anatomy, where everything is, right? Up, down, left, and right. Remember we talked about in lab, orientation is the first thing you have to identify when you're looking at a structure. And remember, the left side is over here because that's our patient, and the right side's over here because that's our patient's right. Not our right, not our left, but the patient's left. And you could see everything here on the right side is blue. Therefore, the convention is red blood cell will have the majority carbon dioxide. And everything here on the left side of the diagram, red blood cell is oxygenated. Now, let's look at the practical application of all of that. The practical application, and those of you who are in lab can see that this diagram looks nothing. That box looks nothing like a real heart, but the box is simple. And you can actually kind of draw the box here, see? Where it's like that plus sign? And then you have doors here and doors here. You identified that this is the left side of my patient, this is the right side of my patient. So let's go through the cardiac cycle looking at this diagram, and then again, the same. And if you want some pictures of an actual heart, you can look it up, of course, Google it, or email me. I have pictures from previous labs where we had practical exams where you can test yourself. So we started in the left atrium. You go through a valve, and it has 2 doors. Do you see there's 1, 2, right? But again, in real life, were we really able to see, how many doors? No, it was just like a crumpled up mess. But we now know that the crumpled up mess has to be 2 doors, also known as your bicuspid. And I now know I'm in the ventricle because you see this trabeculae carnae. Now, these leaflets or cusps, right? They're called bicuspid. They're held also with these cords, and these cords are called chordae tendineae. That's how you spell it right here. And the chordae tendineae are connected into these little muscles here. They look like fingers, and those are your papillary muscles. So the papillary muscles pull on these cords, and then it allows the blood to flow through. I want you to think of these cusps, these leaflets, and these valves here as well, kind of like an upside down parachute. And you know what happens to a parachute, right? I could hold it in my hand, right? The blood, but if I tug and pull on the middle part or the bottom, it'll sag, and then all the fluid will go down. And that's actually how all of these valves work. Now we go into, it goes, now how do we exit? There's no tube down here, but I know there's got to be another hole exiting the left ventricle. So blood comes down this way, and then you see here, and that's the one thing that, because probably I was yapping too much last night, but I saved the hearts. So when we have our second session, we can start sticking probes in our fingers in these holes and to see where they end up. And if you stuck a probe through an aortic semilunar valve here, you will of course end up in the aorta, your largest artery, and then out to the outside world. And then once it goes out into the outside world, it comes back, and it comes back here. If it's from your head, superior vena cava. If it comes from the rest of your trunk, inferior vena cava. And those of you who looked at the heart last night, we weren't able to see this because they removed this and this. And if you recall, this was partially like obliterated right here, and we only could see the sides. But then again, it goes through one door. And this particular door has 1, 2, 3 doors. Tricuspid, and again, you have your papillary muscle here, chordae tendineae here, and then it goes out through a semilunar valve onto our lungs through our pulmonary artery. And of course, there's a left pulmonary artery and there's a right pulmonary artery. There's left pulmonary vein and a right pulmonary vein. And it makes sense because you have a left lung and you have a right lung. So this this pulmonary artery and the pulmonary veins here, when it comes back, they get split into both right and left. So you could see how the box diagram helps you look at something more complex, but in a very simple manner. And knowing it, my main message last night regarding the skill set of concept map, you could see how we learned it like a story or like a pathway. So you can do that when you're, for future reference, when you have laboratory practical examinations, you go through the whole process. Am I on the right side? I'm on the left. Who are my players on the left? Are they oxygenated? Are they deoxygenated? Am I in my atria? Am I in my ventricles? What's the difference? What's the difference between an artery and a vein? And we saw it yesterday, especially if some of you took a look at the other side of the classroom when they were looking at the kidney. The aorta or the artery, it was hard, just like the heart. And the hole was open. But if it was a vein, the hole would be like all flat. It would be way more flimsy than this artery. Okay, so that's the heart diagram, and I can have that video available for you. And of course, the actual drawing, the actual picture, and you could see how this is how the heart diagram makes your life easier. Now, let's look at the external structures real quick. And we already know, let's go anterior versus posterior. We already know, for those of us who had lab, we already know the difference between front and back. And it took us a little bit, what? No, I don't want Quizlet. And these are nice, Quizlet and things like that. You click on these things and you see there's blanks and you can fill them in. And remember how, what's the best way to prepare for the exam? Actually go through, I hate Pinterest. Actually go through an exam. Anatomy, no, here you go. Okay. So right off the bat, how do I know something's anterior versus posterior? The two giveaways in the anterior view is if you see the atria here, you have your right atrium here and your left atrium here, that's in the front. So that's how you already know you're in the front. And the other giveaway is your anterior interventricular sulcus. And a sulcus is, you know, that little groove, right? In lab, we didn't really see the artery and vein too much, but that groove is going diagonally, right? Kind of here and not towards the apex. So those were the two giveaways. And remember, the clinical significance of the anterior interventricular sulcus not only separates the left ventricle from the right, but this thing right here, your left anterior descending artery, is the most common place of obstruction, which will cause a heart attack. 9 times out of 10, something like 94% of all heart attacks have an LAD infarction or an LAD obstruction. Then it causes left ventricular problems. Your left ventricle will start to die, and that's called a myocardial infarction. And again, we're not worried about the heart attack. We're worried about the heart failure that this will bring. Now, how do you know that you're in the posterior? Well, if we had all the arteries and veins intact, you'll start to notice there's the pulmonary veins, there's two sets, and the pulmonary artery will have two sets, a left and a right. But last night we had a specimen that they cut all this out. Another thing we could also see is that the posterior interventricular sulcus goes right down the middle, and you could see how it's kind of going towards the apex, and it directly connects into the coronary sinus, which is a relatively larger vein in the posterior portion of the heart. So that's how you know front anterior view versus posterior view. And also remember, the heart is covered by the pericardium, which helps protect it from damage and from infection. And the pericardium has two layers, your visceral and parietal layer. And remember your medical terminology. Viscera means guts. So the visceral layer has to be the inside layer, and the parietal layer has to be on the outside. And many coverings in your body have at least two layers, and the visceral layer is always the inside layer. Now, in between these two layers, just like the pleura of your lungs, there's a little bit of fluid, and that provides lubrication because the heart has to expand and contract because it is a muscle. And if that thing gets damaged or there gets blood in there, it'll start squeezing on the heart, and you'll get a pathology called pericardial tamponade, which is not good because then your hearts get squeezed, so it's not fun. I am the master of what do you call that? Let's see. Conduction. I am the master of the obvious. So let's go to the arteries and veins. So let's look at this little diagram I either made. Oh, no, I didn't make it. I got it off of somebody. It's just as good. Okay, arteries versus veins. We already know arteries typically, with the exception of the pulmonary artery, they carry blood away from the heart, and they're usually oxygenated. And remember, the pulmonary system is different because if you recall, the pulmonary artery is blue, right? So that's the exception, right? They are bright red in color on diagrams. We now saw the actual heart in lab, and there's nothing bright red about anything there. But the oxygenated blood is bright red. If any of you ever had a really bad cut that was deep, you know, it was really, really red, like super red. Anyone ever see like an accident where there's arterial blood? But if we look at the blood, when you get blood from phlebotomy, and if you get blood from your vein, you'll see that the blood is kind of maroon or dark red because it doesn't have a lot of oxygen. It has a lot of carbon dioxide. We already now know arteries have thick walls because the tunica media has a lot of visceral muscle on it. But the veins, they're thin. And the veins, they're thin because they have low pressure. Arteries are high pressure. And that's why in an artery, you can feel a pulse. In a vein, you should not be able to feel a pulse. And veins also have valves. Because remember we talked about a moment ago, we talked about how blood only can flow one way. And if veins are low pressure, the blood will sometimes kind of slink back, but veins have valves to make sure that blood only flows one direction. Now, when those valves give out, when you get older, or let's say you have a job that you walk around a lot and you stand around in one place a lot, you'll get varicose veins because that's when those valves start to give way and the veins get fat and tortuous and it gets painful. So a bigger artery has a large diameter, and then they get smaller and smaller as you get further out away from your body, and they turn into arterioles. Remember, O-L-E, the suffix that makes things really small. And then eventually they're going to get into the realm of capillaries. Capillaries are both oxygenated and deoxygenated because at the level of the capillaries, this is where gas exchange occurs. So I'm going away from my heart typically. I'm going in through my aorta and through all my other arteries, and then I end up in arterioles. Let's say I get into something like my brain. My brain needs the oxygen. So the red blood cells, since the capillaries are only one cell thick, you can see how thin they are, right? Gas can go in and out very easily. So if you recall diffusion, I have a high concentration of oxygen here. It's going to go, oxygen's going to go out. But then on the other side, on the deoxygenated side of the capillaries, there's a high level of carbon dioxide in my brain. So I want to get rid of it. And then it's going to go into a venule and then out to a vein. And then it goes through the whole cycle. Then I exhale the carbon dioxide, and then it starts all over again. So what kind of questions could be asked? Arterial and arterial, right? Oxygenated. Venule and vein, deoxygenated. Capillaries, both. Capillaries are the location of gas exchange. Can gas be exchanged through an artery? No, the wall's too thick, got a lot of muscle. How about veins? No, we're already going away from the organ system, and we're already headed back toward the heart. The only place where gas exchange can occur is capillaries. And now you could see here where high blood pressure is not good. It's going to ruin the pressure gradients here, and then blood won't be able to go back and forth. And you can also see where fat deposits and plaque right here, right? Because we'll start filling up these tubes. And then what happens when there's pressure on the tubes? You have increased blood pressure. And remember, the artery has a lot of muscles. What happens when you're tense or stressed out? It'll start to squeeze on the arteries, and then you're going to have increased blood pressure. And then it's going to ruin all the pressure gradients here, and then it's also then going to ruin all of your organ systems. So even though hypertension, we always focus on the heart, like, oh, if you get hypertensive and you're going to have heart problems. You're hypertensive, you're going to have kidney problems, lung problems, brain problems, a whole bunch of stuff, right? For those of you maybe who have some heart trouble, why do you think you're dizzy all the time? Why do you think you're weak all the time? Because oxygen isn't getting to where it needs to go. And that's called shock. When it gets really bad or dangerous, that is called shock. Medical shock is when the body has no longer the ability to get oxygen to its periphery or to where it needs to go. And your body's going to try to keep all the oxygen and the blood in your chest and in your brain, but then it gets less and less and less. And then you guys can figure out what the heck happens next. Remember, we're always thinking about the path. We're always thinking about the sequelae. What's going to happen next? Now, how does the heart actually beat, right? How does the heart actually contract? Well, we already know from muscles is that a muscle needs electricity from a wire, and that wire is a nerve. That particular nerve is your cranial nerve 10, and it's written CN with like a Roman numeral X because the Roman numeral for 10 is X. So cranial nerve 10 then connects itself into these bundle of nerves here in your right atrium. The first bundle of nerves is your Sinoatrial Node. That's the pacemaker of your heart. It runs typically around 100 beats per minute or so, but you know that 100 beats per minute is a little bit fast. So you have an AV node here, which is like the brakes, as in, you know, brakes on your car. So the SA node says, okay, this is the pace. But the AV node says what? Okay, let's slow it down a little bit so that it buys time for the atria here to fill, and then for the blood to fall down, and then for the heart to contract. So all of this has to be coordinated. So you have firing or electrical impulse, also known as an action potential, to your SA node. Then it goes to your AV node. Then it goes to the bundle of His. Right? His is a common name. Some guy named His at the turn of the, I think like 1500s or something. He's the one who figured this out. He was a histologist. Then he had left and right bundle branches that go down your septum. And then the electrical impulse then goes into your left and right ventricular walls through your Purkinje fibers. And yes, another histologist named Purkinje named those fibers. I hope one day to find something in the human body so I can name it the Garais fiber or the Garais ventricle, who knows. So when you look at this, it starts off with a pacemaker, SA node, goes to the brakes, AV node. It goes through the bundle of His, then divides into left and right bundle branches, and then from the bundle branches, it goes to the Purkinje fibers. Now, if you look at this video,
the cardiac
right? If you look at this video, I'm going to let it run in a moment. You could see how the electricity can move, can cause your heart to contract, and we can actually measure that electricity on a machine called your electrocardiogram, and that will also. I like this video because it makes the correlation between the electricity and the actual physiology on how the heart actually pumps. Without further ado, here's the video.
System consists of the following components: the Sinoatrial Node, or SA node, located in the right atrium, the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The Atrioventricular Node, or AV node, located on the other side of the right atrium, near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the
now, you don't
nodes
really
and
have
the
to know
cells
this,
of
but
the
it's nice to
myocardium.
know for future reference.
Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires. Electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the
So you
SA
see, there
nodes
has
to
to be
the
a pause.
AV node. The
And that's what the
QRS
AV node does
complex
for
marks
us.
the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of
And
the
you can now see
ventricles.
how much more force, how much more
S wave
electricity is
represents the
required
last
for
phase of
ventricle
ventricular
versus atrium.
depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole.
So you could see here, remember the majority of the rest or repolarization of the heart is like in the S and the T area. That's why you have STT changes in heart attacks. Because remember we talked about the left ventricle? That was the most common site of damage of a heart attack. So heart attacks, you'll see STT changes, and even this T wave gets inverted. So you could see how the electrical impulses match towards pathology. That's why the EKG is really, it's once you know and understand this, it's actually really simple. So if you see anything wrong with this P wave, you definitely know that it's an atrial problem. If there's something wrong with this, like in a heart block, the time between this and this has to happen. If this distance gets messed up, you know that what? The AV node, the brakes didn't do its job. Okay? And like I mentioned earlier, you could see how it doesn't take a lot of electricity to pump the atria because it's low pressure, but you could see how much electricity is required to pump the two ventricles. Way more, a lot more, almost 10 times more. So you could see how forceful the ventricles are. And I'm going to include that video as well. So that's the cardiac conduction system. Remember, it connects into your cranial nerve 10, and the cranial nerve 10 then connects into your SA, AV node, and this whole entire system. So that's exactly how your heart pumps. And you could see that it has to be in a coordinated fashion, because if this thing starts to fail and it has a disorganization, let's look at what defibrillation looks like. It's actual. Well, it's not defibrillation, fibrillation. Because defibrillation is, so let's look at this. That's, it's already working. I want to see it not working. Coronary artery bypass, no. Minimally invasive. Let's look ventricular fibrillation. They want to show a picture of it. Well, you can see this is a typical ventricular fibrillation pattern. You can see there's unorganized, and if it's unorganized, it can't pump. I want to show you an actual. There's one that was actual, and it was in the middle of surgery. That's the one I just saw. I think this is the one. See, we're using a cautery gun to open up. See, did you see what happened right there at the end? You see? Here, you see the heart here? This part was beating normally. Lub dub, lub dub, lub dub, and bang, something went wrong. See? He's now calling for suction, and they're calling to stop. So you could see how it the best way to describe it is like a bag of worms. And that to any cardiovascular surgeon in the middle of doing that, you can see it was scary. And you can actually notice that if you look at this diagram here, what vessel was he working on? It looked like this one, isn't it? So he was looking to repair and open up the pulmonary artery. But what's right next to the pulmonary artery? You can see this, AV, right? So He probably hit something that he shouldn't have hit, but it happens. So let's see what else. Conduction system of the heart we went through. Yep. Arteries versus vein. Yep. Box diagram. And let's see if I have any notes. Oh, that's respiratory. Let's go back to our main page just to make sure that we went over everything that we went over the heart. And those of you who went to lab, thank you. But now you could see, now that we went through the lecture, right? Now you could see, like, oh, when you look at the real heart, it's not a mystery anymore. And like I was mentioning in class last night, that's one of the things that I love about anatomy and physiology and the basic sciences is that things now I know how things work. So if someone asks me, or even if I just ask myself, how do things work? And when you watch these videos, it makes things much simpler. Now, not going to go over, if you click on cardiophysiology, that lab part and task 6, we already went through cardiac cycle, heartbeat, pulse. Where do you get the pulse? This is like kind of like mini textbook. Systole, I mentioned at lab last night, that's your maximum pressure. That's when your heart is pumping. And diastole, that's when your heart is filling. It's not really resting, it's actually recharging, and it has to not pump so that the blood can come in. And that's your blood pressure. So if you have a blood pressure of 120/80, what it really means is your systole is at 120 millimeters of mercury, and millimeters of mercury is a measurement of pressure. And your diastole is 80 millimeters of mercury. And 120/80 is your typical normal blood pressure for a 70 kilogram male, which is the standard for medical measurement. But if you're like my niece, who's like, what is she, 98 pounds? She has a blood pressure of 90/60. So, and that's her normal. So 120/80 would be hypertension for her. And you could see why I have my own pictures. The pictures in the notes, not so good. Systolic pressure, diastolic pressure, 120/80. And the pressure, the difference between your systolic and diastolic blood pressure is called your pulse pressure. Okay, and your pulse pressure should be, at least 30-40 millimeters of mercury. And this is the thing for millimeters of mercury. We went through bundle of hits, we went through all of that, and you can see how I like my pictures better. A little bit of electrical system, we went over that. Defibrillation, this nice to know. You will definitely see this again when you are in your clinicals, or if you're in electrocardiography with me. And you could look at the notes. They're nice if you're one of those people like to read, and that's the cardiophysiology notes that are in step 2. And step 3 has the blood and blood vessels. What are the 3 parts of blood, which are your red blood cells, your erythrocytes, white blood cells, or your leukocytes, and platelets, which are your clotting cells. Those are the cellular portions of your blood. And your blood is also composed of fluid, which is called plasma. Now, the ratio between plasma and these cells is called your hematocrit. And the function of the hematocrit test, abbreviated HCT, is to tell the clinician the fluid status of your patient. If your patient's dehydrated, they'll have a low percentage hematocrit, and if they're hydrated or overhydrated, they'll have a high percentage, which isn't good. Remember, being dehydrated or overly hydrated, either situation is no bueno. Yeah, you could look at this and eventually, especially you future nurses, got to memorize these numbers. Eventually, you get your lab class, you need to. Leukocytes. Now, the leukocytes If ever you heard that term CBC, which is complete blood count, and you'll hear CBC with diff or complete blood count with differential. Your CBC with diff, the diff is all the different types of leukocytes, and they come in two forms, granulocytes and agranulocytes. The granulocytes have these little granules in it. Let's show you a picture. So if you look at this, wow, it got smaller, seriously? Okay. If you look at this, if you look at the cytoplasm of the granulocytes, there's a whole bunch of lysosomes in it. So it's all like that. If you look at the agranulocytes, there's nothing, this might not be the best picture, but you could see that there's not a lot of leukocytes, because the granulocytes, neutrophils, eosinophils, and basophils, and they call them that because of the stain that each type of white blood cell likes. Neutrophil likes neutral stains, eosinophils likes acidic stains, and basophil likes basic or alkaline stains. And they call them granulocytes because they release these lysosomes, and these lysosomes have enzymes that kill bacteria, foreign body, or whatnot. Now, your lymphocytes and monocytes are derivative of your immune proteins. And in other classes, you'll talk more about that in other classes. But those are the two types. And depending on which ones increase, which ones decrease, you can diagnose certain infections, like infections versus allergies, that type of thing. So that's your granulocytes, neutrophils, eosinophils, and basophils, right? And they have these lysosomes because they love to perform phagocytosis. Agranulocytes, they're lymphocytes, and they're part of the protein immunogens called your antibodies, and you'll learn that in your immune system chapter. All right, and this is a nice, I didn't know it had this chart. Learn something new every day. Do you see how the differential, like if I have increases in neutrophil, then I definitely know it's what? It's a infection, stress, trauma. So it could be anemia, viral infection, right? That's why I find it very, very funny. And I'll say this a million times. I might sound like one of those conspiracy nuts, but a lot of people in internal medicine are really upset that CDC, World Health Organization, and the Department of Health will not release what is in the testing for COVID. Because I have a friend of mine who works at GW. He says that when they test certain individuals that are positive for COVID, the differential profile doesn't match. It doesn't match like if you have a viral infection. So that begs the question: what is this thing testing? And in medicine, I don't like the one-all catch test. And if I have a one-all catch test, I do that test at least twice. But of course, cost and limited supply of tests. But for me, the biggest thing is what the heck's in the test. They're very vague about it. And last time I remember, viral tests don't take minutes; they take days. But ask anyone who's ever been diagnosed HIV positive. They have a good 5 days where they have to wait. They have to wait for a definitive. So it's just something to think about, and something to spark more conspiracy theories. But we're in science. We need answers, and we need to, because we like having numbers, and we like having physiology, someone to explain to me exactly how things go down. So let's do next week, right? Hopefully you'll take advantage of the July 4th weekend and try not to blow up something that you can't run away from. So That's always my theory. So task 6, which is concept map of all the stuff we talked about. And let's look at the discussion.
Oh, the video in the discussion wasn't working yesterday. I tried to play it.
Okay, I'll find you.
A link.
Find you. I'll.
A link or
I
something.
think.
Okay.
I think I have a link in the previous class.
Okay. All right.
But when I look at it, don't worry about the video. Look at what you had to post. Innovative ideas in medical technology that will enhance people's lives. So look for something brand new, 2020, something from this year that is brand new medical technology that will actually do something for somebody. Many times, like we have technology, right? Like our cell phones are so advanced, all the websites are so advanced, but we have to ask ourselves, does it actually enhance someone's life, right? You always heard from me in the short time we were together. I'm internal medicine, but I don't like medicine. Medicine makes things worse, especially psychiatric meds, in my opinion. Makes things far worse. And it doesn't enhance people's lives. But try to find some sort of medical technology that actually has evidence of enhancing someone's life. And remember, get an evidence. Don't just put a citation that, hey, this looks good. It's from, National Institute of Health. Yeah, but does it match to what you're saying? Okay. So make it match to what you're saying and actually take something from it. Okay. You don't have to quote it, like put it in quotes directly, but try to blend it with your thoughts. Let's look at the lesson. Oh, I hate when I do that. I should always touch only up there. Good. Let's look at the lesson due next week. And those of you who are getting a B- or lower, you will be getting an official email from me probably by Friday outlining what you can do to bring your grade up, right? And because many of you are striving to apply to the School of Nursing, if you get something lower than a B- in the class, it won't count. So please, 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 always shoot for that A, always shoot for the higher so that you don't get into trouble. But I don't think anyone falls into that category for this particular class. But watch your official Stratford emails, because there are many times where, the Moodle doesn't properly record the grades and the teacher only goes by what the teacher sees. Because I gave a D to somebody last term and they were like, oh, Dr. Garais, I got a B-. And then when I checked it again, Moodle didn't count a whole bunch of grades. So always watch your grades and always be in cahoots with your teacher to, so if, let's say if I answer you back, oh, you're gonna get full credit, and then later on that day or that week, you still see a 0 or you still see a grade as blank, even though I said, yeah, I posted the grade, please give me a call, because so that the grades will be accurate. So the assignment, of course, do the thing, download the case, story of the very hot tub. And again, I'm not a fan of these, but it's part and parcel of the course. Part 1, read it, questions in part 1, part 2, questions, and yep, part 1, part 2, part 3, questions. Kindly submit in a Microsoft Word document, only the answers. Please don't put your answers in the comment section of the submission, because it obscures my grading. It like takes up all the space and pushes everyone's grades where I can't really see it. And if you have a problem with submitting, again, your backup is always submit via email. All right, does anyone have any questions? What's due this week or next week?
No, but I have a question about the lab times. If
Yeah, shoot.
Yeah. So I see in week 7 next week on July 6th and July 7th for this class MED110,
Okay.
there is term 3 session 1 on an evening session from 6 to 9. And then Tuesday, it doesn't, on July 7th, it doesn't have any times. For this class for MED110, are we required to go to both sessions, or are they both the same
No,
session?
just pick one.
Just pick one.
Because like yesterday when you saw there were night people going in the day and day people going at night. They were all going. These are just opportunities. And actually, next week I got people from different classes going to different things because many of our students work in the healthcare field, and they're because of COVID, their work schedules are week to week, right?
Okay.
And it's so that's why I have to have you guys do sign-in sheets, and it's your due diligence that you and I calculated it. Your laboratories cost something like 4.5% of your total grade. So like I was mentioning to a student last night because she was going for some sort of scholarship or something. I was telling her, you miss one lab, it's not the end of the world. So if you're already getting an A, right, and you miss a lab, you should be still in the A- range. But she went to the lab because she needs for her scholarship to get into the A range, right? So, but if you go to both labs, you get your 9%, and you could be good to go, right?
Okay, so we can either go to both or just choose one or the other.
Yeah,
So,
choose
and
one or the
so you're
other.
saying,
But as you saw in class last night, it fills in a lot of blanks.
right.
And also, guys, look at your payment plans. You guys paid money to go to the lab, so if you don't go to it, they don't give you your money back.
Right.
So go to the lab. And also, like I mentioned, I'm not sure if I mentioned it to your lab in the morning, but I definitely mentioned it at night, that it's your lab. If you want to come in and practice something on a tutoring one-on-one basis, give me a call. I don't get paid by the hour. I'm cool with coming in on a Saturday or a random evening and to help you enhance your skill sets. And the nurses do it all the time. They're there, like even on days where there's no lab, nurses are there like Saturday, like 8 a.m., 9 a.m. The nurses are constantly practicing their skills, and their proctor shows up. And if their proctor isn't available, I can show up, right? So take advantage of your school. You paid for it. And it's a lot of money. Come in extra, because that's your place. And then when hopefully when we finally get to open up full time, my wife, even though she's not a student, she always used to come to work with me, like on the weekends and in evenings, because you got to admit it's a better study environment than your house, and it's called conditional learning. That's where you're going to have your exam. So where's the best place to practice? On the actual battlefield. Because I can't study in my house. I barely can do these lectures here. It's so comfortable. I'm here on a leather couch. I'm in an air-conditioned room. Oh, this is nice. You think this is fun part, but do you think I'm going to be able to do any work here? No. So later on this afternoon, I have to actually go to the lab, because I can't work. Working at home is happy time. So pick a place, especially when you study for exams and train for exams. Pick a place that's that looks and feels like school. And that's my 2 cents about taking advantage of school, because I took advantage of nothing when I was in college, and I had a huge bill that took me 8.5 years to pay off, and I feel cheated, to be honest. And that's why I'm always telling students, take total advantage of us and our labs. Okay?
Okay, thank you.
Shoot me an email for session 2 to confirm, and then same protocol as we did last night or yesterday. All right, ladies, have a good one. And I'll see you when I see you. And where's
All right, thank you for your time, Dr. Garais.
All right, have a good one.